Hello everybody, and welcome to How to Evaluate Radiology AI Lessons Learned from Clinical Practice. We are really honored that you take the time to be with us today. We got really great number of people who registered for this event, more than 230. And we are excited to share insights with you to hear and discuss about how to evaluate AI in radiological practice, in clinical practice. My name is Georg Langs. I'm Chief Scientist with contextflow, also Professor of Machine Learning and Medical Imaging at the Medical University of Vienna, and I'll be moderating today's event. It's a collaboration of contextflow and Collective Minds, and I would like to thank especially Collective Minds team for helping to organize and set up this event, Dan and Saidul and their team for setting everything up, getting everything in place so that we can have these talks and interactive discussions today. If you're not already a member of Collective Minds, I think it's highly encouraged to join. It's a platform where you can post cases and get feedback from fellow radiologists, so you can also try out software, and we get to that a bit later. contextflow develops deep learning software for chest CT diagnosis, and we are collaborating with Collective Minds to let users just try out and evaluate the software, and also to use the Collective Minds platform for FDA studies, for reader studies that enable us to evaluate the software for regulatory purposes. We have a great pair of panelists today, and that's really the core part of today's webinar. Our guests today will each present a short presentations on their experiences in evaluating artificial intelligence in radiology, and then we'll have plenty of room for questions. After the two talks, we'll give you a brief demo of Collective Minds and contextflow, just to show you how the platform works, because also quite a number of you have signed up as they have registered for the webinar, and all of your signups will be activated right afterwards. I think the main part of today's webinar are the talks, and then a lot of room for discussions and questions. So if you have questions during the talks, please post them into the chat. The panelists will see that, but I will make sure that we will collect all of the questions that are posted to the chat, to the Zoom chat in the end, and they will all be asked during the discussion session. In prior events, there was also a very, very lively discussion that really went for quite a while and got into a lot of detail, and I'm really looking forward to that here as well. So you are important as contributors to these webinars as well. First, I'd like to welcome Dr. Henriettae Stahlbrandt. She is practicing radiologist and deputy director for the region Jönköping in Sweden. And she also serves on the board of the Swedish Association for Medical Radiology and has been a very early tester of artificial intelligence, including contextflow. And so I'd like to you to join me. Please welcome Henriettae, and I'll hand over the screen sharing to Henriettae, and I'm really looking forward to your talk.
Thank you so much, Professor Langs. So I'll just share my screen with you guys. There you go. So we did try, and we are still trying out the contextflow solution in our region, and I will tell you a bit about how we decided to go with contextflow and how to evaluate and validate that AI solution. However, I will not tell you the results of the actual solution, because I think that is something that is so local that you need to try that for yourself. So just as a brief overview, we are in the south of Sweden, which is a very long country. And we have 3 emergency hospitals, and we are trying this AI in all 3 hospitals. We also have 4 outpatient clinics. We have 7 cities, of which all of them are using this AI solution. We are using AXA Enterprise Imaging for our recent packs, and we are about 60, 70 radiologists, including residents. We also have an internal IT department within the radiology department, which is, I think, one of the more important things when trying to implement an AI solution within your department. And I would speak a bit more about that later in the presentation. So we have used, and I am sorry, this right slide is in Swedish, the right part of the slide. You'll just have to listen to me instead. But we have, since a couple of years back, had an AI strategy in our department that says that we are not a university hospital, so we do not want to develop AI solutions, and we do want to work primarily with known vendors that we have in our department already. We are also trying to get AI suggestions from radiologists or radiographers, depending on which AI that we want to try. And the right part is how you go about when you're a radiologist or a radiographer trying to or wanting to implement a certain AI. You have to fill out a form, and you have to get it to the AI group that we have in our department. And as I said, we are trying contextflow as one of our AIs. It is not within our known vendors already, but it was a suggestion from one of our radiologists, and more specifically from the thoracic group of radiologists that we have in our department. So that is the reason why we are trying out contextflow and the advanced chest CT solution. So what we do have is an AI group within the radiology department, and it consists of a number of persons. First, it's the director of radiology, and he's also a radiologist. He's in this group because he was so interested in AI that he really wanted to be part of the group. And he comes up with some very important information and how to help us to evaluate the AIs. We also have a radiologist in the group, which is me, and a radiographer, which is my co-deputy director of the radiology department. So all of us, the three persons that are the main management of the radiology department is within this group, and we feel that sends out the message of how important this AI is going forward. We also have one of our two mammography managers within the group, and she's only present when we are talking about AI within the mammography department, so not with general radiology. We have an IT planner director who is our contact with the rest of our three hospitals and the larger regional-wise IT department that we have. We have the IT manager within the group and three IT engineers from our internal radiology department. One is from the mammography, and she's also only present when talking about mammography AIs. And there's two from the general radiology department. And we also have a controller because part of the evaluation of whether or not to keep an AI is to see the cost benefits from it. So she's important in that part. So we have a 5-phase implementation of AIs. And the first part is the initiation, and that is when someone or a group of persons want to try out the AI solution. They have to tell us why they want to try it and what they think the benefits are, and then they go to the AI group, and the AI group decides whether or not to move on. And if we decide not to move on, of course, we communicate that back to the interested parties. If we decide to go on, we evaluate the AI. We do it with a retrospective analysis, and Collective Minds Radiology could definitely be a part of that. We did not use it in this AI solution as we were early adopters and it wasn't available at the time, but we are doing it with other AIs in the future. We also, and after that initial evaluation, again, there is a go, no go and communication of the results of that go, no go. The third phase is the preparation, and that is where we have to buy the program, we have to prepare the technical integration, and of course there's a go, no go after that part as well. Then we do a phase 4, which is a limited implementation. So we, if possible, we put the AI in the background to have it running in the background. But that is only if it's possible and doable for that particular AI solution. And we're also doing implementation just within certain groups of interested radiologists or one of the hospitals versus the 3 hospitals to see again if this is an AI solution that we are interested in. And if all of those phases have passed as a go, then we will do the full implementation, and we do a yearly evaluation within the interested parties. So in the contextflow case, this is the radiologist group that do the yearly evaluation of whether or not they are using it and whether or not they want to continue with the AI. And I just included a couple of references here if you want to read further about how to implement AI solutions within your local departments. We found them to be very helpful. And so one of the parts of this is trying to figure out how to validate or measure improvement within the particular AI solution. And I think that has to be something different for every AI solution because they are doing different things. For this particular contextflow solution, we said that we think that the AI solution will make us do less nodule controls with the CTs. And therefore we gain time both at the radiology department and the lung medicine department. And we then asked the lung medicine physicians if they have a subjective feeling of that there being less lung nodule controls. And we also look in our controller system if there are fewer lung nodule controls actually performed. We also looked at the turnaround time at the radiology department. And we looked at the turnaround time from the exam to the answer to the referrer. So everything from the exam being performed to the referrer actually having an answer in their IT. We also looked to see if the radiologist thought that they were being quicker of doing the readings. And we, of course, looked at the median reading times to see if they were actually quicker. And the third part that we evaluated was the readings and whether or not they had a higher quality to them. So we looked at if the radiologist felt subjectively more confident in reading the CT thorax exams, both for lung nodules and for lung parenchyma. And we did then, together with Collective Minds Radiology, we did a questionnaire, or we did an audit, I should say, for 50 exams to see how the AI solution was performing. And we also asked the lung medicine physicians whether or not they thought that the radiologist readings were of a higher quality after the AI solution had been implemented than before. And that is the one that I was touching upon with the Collective Minds Radiology. So to summarize it, we looked at the volume of our exams and if that was changing, the time to read the exams, and whether or not the exams had a higher quality, or the readings had a higher quality. And that is my presentation. Thank you.
Thank you, Henriettae. And we'll go immediately to our second speaker. Our second presenter is Dr. Erik Ranschaert. He's professor at Ghent University, and he's also a board member of the European Society of Medical Imaging Informatics. And I think many of you might know him as he's very active in the radiology AI community and known as one of the key opinion leaders. He's a radiologist, scientist, a teacher, an advisor, and an entrepreneur. So I think like he knows the scene and the development that has been going on over the last couple of years from many different perspectives. And so I'm very curious to see his talk. Erik, please.
Thank you very much for this kind introduction, Georg. Yes, my talk will also about the management of AI implementation in radiology. So how should we do this? And of course, there's some overlap with the previous lecture, but I think this is a good way of showing what the possibilities are. First of all, some disclosures here. Yes, as you probably all know, the implementation of AI-based solutions for medical imaging is increasing, although rather steadily, but all figures are showing this. The AI tools are used to improve diagnosis, but not only for that purpose. There's also other solutions that are implemented to facilitate the workflow. For example, AI can also be used to prioritize examinations and not only to, let's say, evaluate an examination for nodules. The radiology departments, they do face a challenge of integrating those solutions seamlessly into clinical practice, and it also affects the way of working. So it does have an effect on, let's say, the workflow management as well. And the implementation of AI has a wide impact on the whole department, and not even on the department, also on the hospital, not only from the workflow perspective, but also from the administrative, financial, and technical perspective. So this is the reason why a lot of people are always involved when we want to implement a new solution. This is an interesting scheme I wanted to show you just to explain in how many facets of the radiology workflow AI can be implemented. And as you will probably know, I will use my beamer here. So the evaluation at this moment, most of the solutions are being used for interpretation. But as you can see, there's a lot of other possibilities as well. For example, for scheduling examinations, deciding what scan protocols we should use, what kind of acquisition we make. And now, certainly with the upcoming potential of the large language models, the reporting will be largely influenced by AI as well. We can use it for communication, which is also related to the reporting, of course, for recommending specific, let's say, further steps in the treatment, etc. So there's a lot of facets where AI can be implemented, but at this moment, it's mostly for interpretation. Now, what do we have to think about when we implement an AI solution in clinical practice? So it deploying an algorithm has several advantages, but also some challenges. And as I said already, it does have an impact on the management of the department and also of the hospital. And we might even be confronted with a shift in many aspects of the radiological workflow, because we will make use of an assistant looking at the images. So not only radiologists, but also the hospitals that will have to prepare themselves when implementing AI and develop a common policy. And I hope the next slides will make this more clear to you. So that's the main message I wanted to give you. AI can be considered as a driver of change management. And the question is, how should this be handled? Now, what are the potential advantages? First of all, as you know, the diagnosis, of course. With AI solutions, we can improve the diagnostic efficiency and accuracy of our work. We can detect lesions, we can characterize them, and we can follow up the evolution. So this gives us more information. We are confronted not only with morphological information, but also with quantitative information. And this is relatively new for us as radiologists. For the workload, well, AI can help us in automating specific tasks, or, for example, in prioritizing the reporting of specific examinations. The AI can also automate the execution of examinations, for example, for deciding what protocol should be used. And it can also help us in assigning the examinations to the right subspecialty radiologists. The monitoring of diseases is also an important facet. By using AI and solutions like contextflow, we can, let's say, provide a more tailored treatment, because we can evaluate how the treatment is evolving with a specific therapy. And we can also create more efficient and economic treatment plans. And now, certainly, but I will not go into detail, with the upcoming multimodal vision language foundation models, there's a possibility to integrate all kinds of information, which also creates new possibilities for the treatment or the personalized treatment management. There are several challenges as well. We have the technological ones. So the combined use of AI tools is still needed. We have to implement maybe several solutions for different purposes because the most solutions still have narrow functions, and that's already a difficulty. How many solutions will we implement? There's multiple vendors, of course, and this is also increasing the overhead costs when we want to deploy them separately. And there could be interoperability issues with the existing system, with the RIS, the HIS, or the PACS. The question is, what are the user interfaces and how can we integrate them optimally? And of course, regarding the workflow, well, yes, as I said, it will have an impact on the workflow. It might slow down the work even in some cases, or in most cases, that's what they want, the radiologist. It might facilitate and make the work easier. And of course, there's still a lot of, there's a bit of a lack of best practice. It's difficult to prove the value of AI tools, and this is something that we have to think about. At this moment, there's also limited feedback between the users and most AI applications. And what are the organizational challenges? Well, there's, of course, a lot of diverging expectations about AI. Some radiologists will like it, others not. So maybe the expectations might be too high, etc. So there's some things issues that might be that have to be discussed on beforehand and maybe evaluated as well afterwards. And this will also help us decide if an AI solution is functional or not. There's many cases in many hospitals, there's no basic proficiency in using AI. So the question is here, do we have to train radiologists to start using them and to learn more about what possibilities are and what they could expect or should expect and should expect not expect? And there's also maybe some gap between the clinical and the technical expertise. So is there enough expertise available in the hospital to implement these solutions in the right way? And of course, not to forget, we also have to make even new management policies and guidelines for clinical implementation. There's a lot of stakeholders involved when we implement AI solutions, and it's certainly not restricted to the radiology department. So a correct and a safe implementation of AI requires requires consultation with all the others. And I will just mention several of them. As Henriettae also mentioned, she also included several disciplines and expertises in her group, in the radiology AI group. But in general, you should involve somebody from the IT department, the PACS management, the procurement department, so who's going to decide about the price that it has to be paid, for example. The data privacy officer of the hospital should be included. There's a chief medical information officer, which is already the case in a lot of hospitals. There's a CMIO. One of the referring physicians could be included, the chief medical doctor maybe, or maybe the medical council should be included for some issues. The persons responsible for training, certainly in the hospital where you have residents, the board of directors has to be informed. There's a medical ethical committee that needs to be informed as well. And of course, we should not forget the patient advisory board. What are the safety, security, and ethical issues? Well, of course, implementing AI needs the implementation of a robust data governance framework so that we can handle patient data securely and responsibly. And this is also the reason why we have to involve people like the DPO or the CMIO and even the medical board and the board of administrators, because there's a lot of facets and a lot of people will have an opinion about this. The medical ethics committee is very important because they have to approve the way in which patient data are processed and used. And also, should not forget, there's several contractual agreements that have to be made and assessed before they are formalized. And of course, this is something that goes on between the hospitals and the vendors. So there's also a lot of people that have to approve this. And then, of course, the patient advisory board should not be forgotten. The cost and financing of AI is also an issue, of course. The implementation of AI itself, not even the license, but the implementation, it involves human resources. So we need a radiologist time, we need IT time, we need HR costs, etc. That has to be included in your cost calculation. So this is also what makes coordination between all stakeholders essential. Because if you want to do this in an efficient and economic way, and if we want to implement solutions seamlessly, well, then the communication between these stakeholders is essential so that we can minimize cost and effort. An efficient framework and platform is needed to reduce the cost of implementation several solutions. I will show you this in one of the next slides. And of course, we have to be able to have financial resources available. They have to be found and agreed upon. And of course, for that purpose, we should also think about the return on investment and the financial impact as an element of the permanent monitoring process. So it's not only at the start, but we should also see what is the effect in real time. Is it really achieving the goals we want to obtain? So how do we tackle this? And I just wanted to mention these several issues: the holistic approach, the coordination, the phased implementation, and then the communication. So the solutions that I propose here are from three perspectives. First of all, the technological one, secondly, the workflow one, and then the organizational one. So this is based on a publication that I will refer to later, but it's a very recent publication about the holistic approach they used in a university hospital in the Netherlands. So what they do there is they work with the vendor neutral. Oh, I'm sorry. I'm not sure why this is. Okay. They work with the VNIA, which is a vendor neutral AI platform to orchestrate the distribution of data towards, for example, different AI solutions. So this is kind of an implementation that focuses really on the workflow, and it also guarantees a seamless integration with the front-end software, which is the PACS viewer. I will show this in the next slide, where you can see the scheme of this VNIA. Then, of course, the workflow also needs to be orchestrated by this platform so that the results can be delivered timely in the right places. So this is also avoiding the unnecessary workflow disruptions, which could disturb radiologists in their workflow, of course. And then, of course, there has to be a way to provide feedback by interfaces, creating APIs, that's how they call this, the feedback interfaces, which could also be could be offered in a more homogeneous way by using this platform. And from an organizational point of view, a VNIA allows centralized monitoring, also centralized contracting, technical maintenance, etc. Which is essential is also the creation of a clinical AI implementation group, which is also something that Henriettae was referring to. This is the scheme of such, in this case, cloud-based VNIA, vendor-neutral AI platform. So we will briefly discuss this. First of all, the patient data have to be acquired. This can come from several modalities. Then this platform picks up the new patient data, and this way the workflow engine is activated, which is based on a protocol. So the data are fetched and sent to the correct AI solution. Once that is done, the data will be sent to relevant clinical data repositories. And then, of course, the results of the AI, they have to be displayed in the front-end software, which is the PACS. So this is the way this could be organized. I'm here referring to the reference where this information can be found. It's a recent publication in Insights into Imaging from January this year. So this system is referring to a centralized coordination. So the CAI, the Clinical AI Implementation Group, is very important. You can also call it an AI governance committee. The purpose of such a group is to help the radiologists and other clinicians who have limited experience in selecting and investing in the right AI projects, because there will be a lot of clinicians asking for that, more and more, not only radiologists. The group could also oversee all the deployments across the institution so that they have an oversight. And they can also ensure safe and effective use of AI tools so that the workflow can really be improved. And more important even, the patient outcomes can be improved. So what are the tasks of such a group? It's to define policies and protocols for implementing AI solutions. It's to assess the viability of each proposal. Is it feasible or not? The task is also to prioritize, to make selections. What AI project will be done first and why? So they have to prioritize and approve new deployments They have to allocate resources as well. And then, of course, they will have to monitor and potentially revoke the use of solutions on basis of clinical assessment. So this is based on feedback, of course, and evaluation afterwards, which is really essential. And of course, potential research and commercial opportunities can be explored as well. So who is in such a committee? Well, you should look for senior leadership from the clinical research and medical informatics operations. And you could also include data scientists, so legal and ethical experts, etc. This is also important, a brief approach. This is also what Henriettae is doing in the hospital. So first of all, you have this committee, the CIA or the AI governance committee, who decides what kind of solutions will be deployed and evaluated. And then you have the implementation, where you can go, that's the best way. This is also what Henriettae did in 3 phases. I personally also always do it this way, 3 phases. And the first phase is the retrospective deployment, where you can use a platform like CMRAD or another system to look how the AI solution is performing on examinations that have been executed already. And then you have to do it in a limited way, a shadow deployment. And then, of course, if you have obtained approval from the group, then you can decide to go for a full clinical deployment where everybody can use it. So this is another way to show this. The phase 1 is the shadow mode phase, where the pilot performance is where the assessment is done in a pilot model. And then, of course, the AI government committee decides to proceed or not. And then in the second phase, you have a limited deployment, which is kind of a shadow mode with a certain group of radiologists. And then, of course, also feedback is provided to the decision group of the governance committee. And then, of course, in the later phase, the third phase, you do full clinical deployment. And then, of course, you also have to think about a dashboard for monitoring the ongoing performance. That's something that does not stop, of course. And also there, the information needs to be provided to the AI governance committee. So this is the monitoring process, which I was talking about, which is quite essential. And it's critical to identify issues such as data drift and systematic disagreements between radiologists and AI predictions. So these monitoring dashboards, they should be used, and alerts should be provided, or automated deactivation of specific tools on the basis of the predefined performance thresholds. So this information needs to be discussed as well with the governance committee. This is actually causing a cultural shift. The radiologists, it's needed that they gain a comprehensive understanding of the strengths and the limitations of AI algorithms. Radiologists must also actively participate in the validation and the fine-tuning of algorithms, and a policy is really needed regarding the reporting and the storing of AI results. Who can see it? Who can see it? Who cannot see it? Department leaders, they must foster a culture of continuous learning and innovation, which encourages staff members to embrace AI technologies as a valuable tool in their practice. And that's also something I wanted to mention. For every subspecialty, a local champion should be nominated. The main tasks of radiologists, they can shift from primarily interpreting images to overseeing AI systems and validating the outputs of the AI analysis. So this is also why training programs should be provided, not only for the experienced radiologists, but also for the technologists and the radiology residents. So to conclude, the integration of AI-based solutions in radiology, that marks a transformative shift in medical imaging practices, offering the possibility to improve accuracy, to decrease the workload, and even to provide personalized medicine. Also important to mention is that a holistic approach is needed to address all issues, like the technical ones, the organizational ones, and the workflow-related ones. A clear vision is needed, not only within the department, but also within the hospital, fostering a collaborative environment for all participants so that they can work hand in hand and increase patient care and outcomes. And by embracing these advancements and proactively navigating the challenges, the departments and the hospitals will be able to unlock the full potential of AI to revolutionize medical imaging and positively impact the well-being. So this is where ends my presentation, and of course I will welcome every question. Thank you very much.
Thanks a lot, Erik, for that fantastic talk. I'd like to encourage at this point, really everybody, put your questions into the chat. We will pick them up. I myself have quite a few questions which I will start, but please think about the two talks and put your questions into the chat so that we can pick them up. Before we get into the discussions, I would like to share a couple of minutes time showing you the Collective Minds framework for evaluating AI solutions. So I hope you can see my screen. Essentially, it's a way to collaborate between radiologists. Quite a few of you have signed up during the registration process to be given a membership and registration, and also be joined to the Collective Minds and contextflow group. The network is overall 18,000 radiologists. You can collaborate, you can upload your own cases, you can look at the cases of others. And I think particularly in the context of AI solutions, that's relevant because you can also try AI solutions in this retrospective evaluation before you actually kind of use and install them. So you can use them, you can upload cases, run the AI solutions on those cases. And it also means that you can have a look at how these AI solutions work on many, many cases of other users. So you immediately get a bit of a feeling of how robust and how well these algorithms work on essentially multi-center data that is uploaded by different users. And I'd like to show you what you will see once you're signed up. So I've got one group here, and I'd like to just run you quickly through what you can do with these examples of the contextflow software. So in this contextflow demo group, there are right now 173 members. There are a couple of cases, quite a few cases uploaded. And these were uploaded by different users, some of them also by us for this demo. And now you can have a look. Let's choose one of those cases and look at what the software does with the case. So this is an example where we get an active interface. So again, that's all working in your browser. You can interact with the case. You can look at the entire, in this case, chest CT of the lung. The software in this case has detected different anomaly patterns. So in this case, primarily emphysema, a little bit of ground glass, and a little bit of reticulation. You can see it in the CT itself. You can also see kind of the overview of where it is located. It has also detected a couple of nodules in this case. And for those nodules, it has essentially calculated a risk score or a prediction score that tells us something about the probability of that lesion being malignant or benign, which is kind of a nice added information about the particular lesion. So you can do all of these interactions. I chose a second case that I wanted to show you because there it means that every case does not only have to be like a single volume, but you can also upload time series. So in this case, that's a patient that has a couple of nodules and a couple of prior examinations, a couple of follow-up examinations. And there you can use, in this case, the software and also this interface to evaluate that, to track each individual nodule in this patient over time. So you can see kind of the last time point here is one particular nodule that has really increased in volume very quickly during the last period between the prior examination and the current examination. You can look at the volumetrics of this nodule and all of that basically in the software, but also in this evaluation interface. And to close it, is this software and many others typically send all of the data and all of the measurements and all of the kind of information they extract from the radiology data back into the PACS, back into your own infrastructure. And you can also use this framework to basically have a look at what is being sent back to the system by the software, what is going back into your PACS as structured reports or as PDF reports that kind of summarize your cases. So essentially, if you have signed up, and I think quite a few of you have, you will be given access in the next hour or so. Will activate all of the access, have a look, upload your own cases, have a look at how many different software packages work on cases coming from different centers. I think it's really a great chance to compare and get a feeling of what these software solutions can do and how robust they are in different circumstances. All right, with that, I'd like to open the discussion. And I'll start with with two questions of my own, and then we go on and give you a bit more time on putting questions into the chat. So I'd like to start with Henriettae. You showed us these phases, and also Erik came back to this concept of having different phases while you're implementing AI in the clinical environment. And what I'm curious about is your experience, where in these phases are blockers, or where there are typically barriers, or are there a couple of barriers that came up often where eventually you found a solution that really made life a lot easier? Is there anything that people can learn from your experience on how to go through that kind of efficiently and without a lot of kind of time effort?
That's an excellent question. I think one of the most important thing is to have as many of the radiologists on board as possible before starting the AI, and that is included in several other phases actually, and also with communication to the radiologist needs to be very stringent in order to for the radiologist to accept the solution. I think we haven't solved it completely. We still have quite a few skeptics within our radiologists, and mainly I would say those of in the middle ages, so 40 to 50, they are the most skeptical. I was thinking maybe the older ones would be more skeptical, but they're very curious and very open to new things. But it's the middle tier that do not want to participate in this. So I think we don't have a solution to it, and I think that a solution is hard to get by. But I think communication and involving the radiologist as much as possible without interfering in their day-to-day work too much, and also as Erik was talking about, making the solution as smooth as possible in order for the radiologist to see it as a help and not as a barrier.
Right. Erik, any comment from your side?
Yes, well, as I said, this is why you need this local champion who can assist the others in convincing them, because we also examined this in a large European survey that most resistance is related to let's say inefficient knowledge and awareness of the possibilities and the potential of AI, and maybe some fear as well, because it might be some radiologists who are not really well informed about AI solutions can be frightened that they might lose their function, or that they that they will have conflicts with the results and their own opinion, etc. So there's a lot of communication that needs to be performed. And also, of course, this is also why you have to, especially if you look for a specific solution like chest CT, for example, that you create a solid group around it with the experts. There's always, in a larger group of radiologists, you have the chest radiologists. I mean, you have to convince them, of course. And then this is why you need this phased approach, because then you can start with retrospective analysis and you show the results to the group. And then you start with a limited prospective evaluation, which should be provide confident information. And of course, you have to first think about the, let's say, the goals you want to achieve. This is kind of the KPIs, you know, the key performance indicators that you have to decide upon. If you want to use a solution like this, what does it need to do? And what goals do we need to achieve? And of course, this needs to be assessed. And then when you have this information and you have done this in a reliable and trustworthy way, then it's usually possible to convince most of the group. Of course, that's always done in a democratic way, I think. So we make a proposal, you show the results, and then you vote. Are we going to invest in this or not? So this is the best way to go. That's what I think. And that's how I did it previously. So that's my experience.
Great, thanks. I think we will come back to this idea of KPIs and in a second, but I'd like to start with one question for you, Erik. You talked about change management, and I'm really curious about that point because like when I listen to the conversations, many people talk about, well, there is one transition that is happening because AI is kind of entering radiology, but also other fields. But I think at the same time, there is also other kind of transitions going on in clinical diagnostics, right? So there is a little bit of growing together of laboratory and pathology and radiology. And all of that is changing a lot of things. And people, I think, are kind of interested in what their position will be in this new arrangement across diagnostic fields. And so I'm curious about your opinion, how AI might be a catalyst or might be something that kind of how this interaction is happening between introduction of AI, but also change of the diagnostic fields and of healthcare.
Yeah, this is a very relevant and excellent question, Georg. This is, of course, also triggering me, and actually I can already tell you that I'm working on a booklet on this topic with other experts in the domain. But yes, of course, we have a new type of information that we as radiologists will have to use. You just showed it. The way chest CTs are being analyzed is of course very interesting, and we have a lot more information, and the measurements will be objective at least, and we can compare with previous measurements, and that will be done automatically. But then, of course, this information is presented to us. The question is, how do we use it? What do we say to our referring physicians? How do we use that information in a multidisciplinary meeting? And how can we convince the others that this is reliable and that they should follow this information to maybe adapt their treatment? This is not only the case for chest CT, for pulmonary cancer, but this can also be the case for prostate cancer, for example. And you do see that more hospitals are now integrating AI solutions also for obtaining these results, these quantitative measurements, and using them in the multidisciplinary meetings to convince the referring or the treating physicians that some decisions need to be made, can be made based upon that information. But there's a lot of trust involved as well. So the question is, how do you manage this? How do you generate this trust in a multidisciplinary environment even? So that's a lot of work to think about. And that's why I'm mentioning that we have to develop a new policy and make agreements about this, not only within the department, but also outside of the department, and involve clinicians as well. I mean, and this is also what Henriettae mentioned, they also talk with the pulmonologists to see how they experience this and what they think about it. And we have to listen to that. And maybe also this type of feedback needs to be provided to the vendors, to those who develop and provide these solutions. So I think that we are still in an early phase, and the more we will be able to integrate this in a multidisciplinary way, the more information we will obtain to improve these solutions. That's what I think about it.
And Henriettae, any point from your side?
I think Erik covered it quite well. I just want to add that I think education of the radiologists is a very important aspect of this, and it is included in the curricula for both residents and fellowships. And I think that is one thing that we need to push upon even further, so all radiologists understand the limitations and the advantages of AI and can be able to explain them to the different clinicians that they are meeting in every day.
Yes, if I can add something to that. So as you know, I'm visiting professor at Ghent University, and I'm already offering the possibility to medical students to make a bachelor or a master thesis about using AI in medicine and in radiology. I mean, because I do think that certainly AI will not be restricted to radiology. It will intrude in all facets of medicine. So medical students already have to be made aware of this and educated about it.
Yeah, no, fully agree. I think I think, Raghu asked a question about how you convince skeptics to kind of join in. I believe kind of that you brought a couple of points how to do that, but if there's anything to add or any specific experience, curious to hear it.
Yeah, what I usually do is stimulate them to give me information about why they don't like it and what they noticed or where does it make mistakes, the algorithm, because usually the skeptics, they always see the mistakes the algorithm make, and to understand better what they see as a mistake. I mean, simple example, if you use an algorithm for bone fracture detection, sometimes the algorithm says, might be, or there's doubt about it, it says doubt because algorithms are just mathematics. They just calculate a probability that something is A or B or something else if they're not sure. But some radiologists are not aware of that. And so you have to learn why they don't accept it, why they are resisting to it. And that's important. And that's also the best way to maybe solve this problem.
Mm-hmm. So I had one question about, I think you mentioned KPIs, but also kind of, I think it's all what's the benefit of using AI, and there are different kind of obvious, maybe more or less obvious points, like for example, time savings or things like that, like not doing something that you really don't like to do because the algorithm is taking away that work from you, like pulling up the right prior cases and things like that. But I mean, there are also other benefits that might be hidden a bit downstream in what happens to the patient, right? So like you might avoid some treatment that was not necessary because of a better diagnosis, or you might save the hospital money in the end because of something that is happening because I don't know, the patient does have to stay a day less in the hospital. But it's all, I think, very challenging to grasp, like where these different benefits might be and who might be interested in them. Because I think some might just respond to say, well, if I get a better diagnosis, that's all I need. But others might, like on other levels of the hierarchy of the organizations, might be more interested in the, as you call it, return on investment. So my question was, could you give us a couple of examples where you found these benefits that were maybe a bit unexpected to you, or that were beyond kind of just time savings or things like that? Either of you who would like to go for it.
I can give you a very simple example. It's an algorithm for bone fracture detection. I mean, that's advantages for not only radiologists, but also for emergency physicians, for example. We evaluated that in several locations. And so they are usually very happy with this because they have immediate results in a few minutes. And of course, they have to learn about how these results can be displayed and why an algorithm is maybe sometimes not sure about if it's a fracture or not. But in general, this is improving their workflow. And this is also facilitating the way patients can be treated. They can be treated, they don't have to wait for the radiological report, especially during the night or in the weekends, etc. So everybody's happy with that. And in general, this has been evaluated. They are happy with it. And this, of course, also is a good way to make the investment, because if you can prove that not only radiologists are working more easily this way, but also the emergency physician, for example, and all others involved, well, yeah, then you might convince the hospital to invest in the solution, or you can make a joint investment, or this could be an additional argument to do it. And then this could be a trigger for new types of solutions as well. But just keep in mind that the AI solution does have an effect on the referring physicians as well. It's not only, so you have to communicate with them. And this will also, let's say, assist you in deploying new solutions.
Yeah. Henriettae, I wanted to ask you, and both of you brought up kind of how to put the group together. And I think both of you also brought up that there is a huge number of stakeholders that are involved, right? From CMIO to the legal department to the finance department, the IT department, but also parts of the hospital or the organization that are involved in policy, what you are allowed to do with patient data and so on. And so how do you balance kind of putting a group together that is small enough to be effective and kind of that you can move forward, but at the same time reaching these other stakeholders in a way that lets you actually move forward?
What I think is that you have to make a core group, a management group with the most crucial people. It's like the radiology chief department, the chief of the radiology department, maybe the local champion in the radiology group who is making the proposal. Then you have somebody from the IT department, the PACS manager, and then maybe a project manager. That's already it. And then, of course, you can also consult the others. But they just have to be aware that this group is existing and that they have the official, let's say, status to do this, that they are not something which has been created only for the radiology department. It should be an accepted committee which is approved. And if you have this status of official of being recognized as an official team, then of course you will be able to obtain advice from others as you want it.
Thanks. Henriettae.
I think it's important to know the local structure of your hospital, because probably there is already something in place covering most of these things, since this is the AI. So AI is a new thing, but implementing these solutions is not new. So in our hospital, we have flows already being built around that and dealing with ethics and patient security and data protection and such. So it's just a matter of knowing who to turn to or who to involve to get into the right flow, so to speak.
Great, thanks. And I had one more question. So first of all, thanks for that. I think I was really curious about that one, because I think like we are also in the process, and many people that I'm talking to are kind of dealing with these questions, how to put together this group that can actually move that forward. But one other effect that I'm curious about was, and again, please, everybody out of the attendees, if you have questions, we have a couple of minutes left, please put them into the chat now. So there is, at least I expect there is a kind of a ramp up time until the real benefits of a solution actually materialize, right? So when you start to use AI software in the first couple of days, you might actually make you slower. You might actually make, I don't know, things might not run as optimal as compared to after using it for a month. And so how do you deal with that when you're evaluating these softwares and when you're trying to estimate how the real benefit will be, that in the first week or so of the software, you might have still a lot of effect of it all being new, people maybe playing around, being really curious, spending time of figuring out how it works. Any ideas about how to deal with that?
Yeah, in my experience, you will always have this difficult phase at the start. There's people, although you provided material to learn more, there's people who don't look at it, who were not available at that time when you gave the education or the training, etc. I mean, there's always issues, and this creates a lot of questions and uncertainty and some discussion. So you have to prepare for that. You have to be prepared. You have to be able to answer those questions. That's one thing. Secondly, of course, you have to evaluate this regularly. At the beginning, that might be more frequently. Let's say you might speak with your colleagues and do this at least every month, and then evaluate this for your own. But somebody needs to take care of that. That's most important. So there needs to, let's simply call it a local champion who's taking care of it and who's evaluating it and just talking with his colleagues. And this is information that you can use maybe to adapt some things where you first thought, maybe you should do it like this. Maybe you can improve it in another way. So that's the first phase you have to go through until you find the best modus to work with the solution. And then maybe a yearly evaluation could be sufficient.
Henriettae, from your side?
I think the local champion is really important, and also to have the communication with the AI company in order to get straight answers for questions that arise in those first few weeks or months even. And I would also say evaluate the implementation at that point, but do not evaluate the AI solution and its results, because it's too early to do that.
Yeah. Maybe Henriettae, like, is that also, like, what's your experience in how much does it play a role that a lot of these softwares are still evolving, right? They have reached a phase where they have to and do provide benefits, but all of them are kind of continually developing. What's the relationship between the hospitals and the software vendors during that kind of continual phase? What's your experience?
I think it needs to be clear what kind of relationship you expect and you want with the AI vendor. It could be one of developing new parts of the software, but it can also be that you want to try it once it's developed enough to use it in clinical practice. So no matter which road you choose, I think that needs to be clear.
Yeah.
I think the type of communication or the feedback you can provide or the support you obtain is also depending on the type of the way you implement your solution. I mean, do you work with a single provider, a single vendor, or do you work with a platform where these solutions are being offered? For example, in case it's a platform, then of course you have to have an agreement with this platform for regular evaluation and providing feedback. This is really essential, and this should be one of the KPIs before you make any contract with such a company. So this is really crucial, that you make a clear agreement about how the deploy or the functioning and the evaluation and the upgrading will be supported. So this is also very important to keep in mind before you start.
Yeah, great. Well, thanks a lot, Erik and Henriettae. Thanks a lot for taking the time. Thanks a lot for everybody in the audience for listening in, for joining the conversation. I would like to point out that we are all going to ECR, so you can have a look at booths. You can have a look at the cases. If you upload cases before ECR, you can have a look at them during ECR at the booth. But primarily today, again, thank you, Henriettae. Thank you, Erik, for joining us, for joining the discussion. I think it was really valuable. A lot of the discussions and the points that you mentioned and the answers that you gave kind of hit points that are, I think, how we say here, driving people around when they are trying to think and figure out how to implement AI in the clinic, because I think we all are certain that it will have a big impact, and it will have a big impact not on its own, but also in how kind of the environment around it changes and takes it with it, essentially. So, and I think now, coming from a technological point of view, so since I'm a mathematician, I think what I'm really enjoying about the community around these solutions is that there's a lot of interactions between the medical experts and then the technology experts, where everybody learns from each other. And that's also why I'm enjoying these webinars so much. And so thanks again. Thanks for joining. Thanks for taking the time. And yeah, have a nice evening, and hope to see some of you during ECR in 2 weeks. Bye-bye. Thanks.
Thank you. Bye.
Bye. Thank you.